Yeah. Good evening, ladies and gentlemen. It's my pleasure to welcome you for this webinar organized by the Sri Lanka College of Obstetricians and Gynecologists, and especially the Subcommittee on Minimal Invasive Surgery, chaired by Dr. Kumar Dissanayake. So I warmly welcome all of you for this webinar. And it's my pleasure to welcome Dr. Rajesh Bodhi from India. He's an expert on laparoscopic hysterectomy. And he's not a stranger to Sri Lanka because he has conducted several workshops here. And most of the consultant has gone to India to learn under his guidance to do the laparoscopic surgery. So I warmly welcome Dr. Kumar Dissanayake, Dr. Rajesh Bodhi. They are going to have two presentations, one on basic steps in total laparoscopic hysterectomy, and then Dr. Rajesh Bodhi will talk on laparoscopic hysterectomy, how I do it. And then we have a panel discussion, again chaired by Darshana Abhegunwardana, our chair, scientific activities, and Dr. Rajesh Modi. So we have a panel of Professor Nishendra Karvaratna, Professor Rasika Herat, Dr. Sampad Ratna, and of course, Professor Mit Gungo from Turkey. So it's my pleasure to read the citation of the first speaker, none other than Dr. Kumar Dissanayake, MBBS, MD, MS, COG, and FSCOG. He has a fellowship in gynec laparoscopic India and diploma in gynecological endoscopy. He is currently the head of the senior lecturer of the Department of Obstetrics and Gynecology in the Faculty of Medicine, Rajaratnam University of Sri Lanka. He is conducting both undergraduate and postgraduate medical teaching and training. He has performed more than 2,000 laparoscopic surgeries, including 100 of advanced procedures. And he received the AFOC Young Gynecologist Award in 2011. So he's a member of SACOG, RCOG, and BSGE, ISGE, and IAGE. So Kumara, it's over to you to start the first presentation on basic steps in TLH.
Thank you very much, sir. May I go with the screen share? Is my screen all right?
Yes, Kumar.
We can see.
Yes.
Yeah.
So today our topic is understanding lap hysterectomy. So it's something very common encounter all of us. And my topic is basic steps in total laparoscopic hysterectomy. So when we take our general picture, so my screen is not shared, I think. Is it?
So your screen is shared, but not in the slideshow mode.
So slideshow mode, yes.
Yeah.
Oh, it's not in slideshow mode. Give me 1 second. So I'll stop the screen share. Already? Okay. Right. Back. Right. So I'll go to the beginning. Sorry. Right.
Sir, if you can just swap the screen because we can see your notes also.
Right.
Just
so is it all right now? Is it all right now?
Yes, it's fantastic.
Okay, right. So I'll start from the beginning. So our topic is understanding lap hysterectomy. I think this one is one of the very important topic for our beginners who are starting their career in endoscopy. So basic steps in TLH is something, this lecture would be one of the best for our beginners or juniors. So when we take the overall picture, so each and every field is moving moving towards the minimal invasive surgeries, like in the, not only in gynecology, in other field as well. So when we talk about the roots of hysterectomy, so we all know about the abdominal hysterectomy is the one of the oldest and commonest even at the moment, and also vaginal hysterectomy, and also other two options we are having with laparoscopic and robotic. So of course, vaginal hysterectomy is one of the route with minimal complications. So it is a good one, and always even the literature says it is one of the best route for hysterectomy. But the problem is vaginal hysterectomy is not suitable for each and every patient. So if the patient is having abdominal pathology, something like endometriosis or any other ovarian cyst adhesions, we cannot go ahead with vaginal hysterectomy. Other thing is the enlarged uterus. If the uterus is much bigger, we cannot go ahead. And so there is technique called ascending vaginal hysterectomy, but again, technically difficult. But when the uterus is much more bigger, still it is not possible. So we are left with two options, laparoscopic and robotic, as the other options. So out of that, I think laparoscopic one is the one which is suitable for countries like ours, because we don't have much funds in the government sector and even in the private sector. So we don't have much facilities to go for the robotic. So laparoscopic is the trend. And not only that, in the future, so the TLH is going to be a day case surgery. So there are a few papers has come out. They are trying to establish TLH as a day case surgery. Day case surgery. So that is the concept which is going to be in the future. So before starting a total laparoscopic hysterectomy, there are few things we need to consider. One thing is patient selection and also the preparation. So preparation, of course, not much different from the general gynecological patient, but patient selection, especially if you are a beginner, we should adapt it accordingly. So if you're a beginner, you should not select difficult cases like with past endometriosis, past surgeries, and also a bigger surgery with large uterus. So patient selection and preparation is much important in that case, and also your team preparation. So that surgical team, the main gynecological laparoscopic surgeon and the assistants and other nursing staff, all should well trained and prepared. So there should be a proper teamwork and understanding, and each person should adapt and efficient of doing own part of the surgery, because not like in open surgery, it's a teamwork. Once you scrub and set into the surgery, you cannot move, and the people we are working with lot of equipment and instrument machines, so the settings of those machines should be done by each and separate people. So we cannot we need help of all the people. And of course, we need laparoscopic system and instrument with a good camera system, and also instrument. So everything we need for a proper surgery. Then before starting a TLH, we have a few more things to consider. That means appropriate positioning of the patient. We all know it's the Lloyd-Davis position. That means legs are a bit apart and bent at knee joints. And so Lloyd-Davis position is a well-known position for the hysterectomy and any other laparoscopy. And also table height should be appropriate to work your elbows in 90 to 100 degrees movements. So if you are a tall person, you have to adjust accordingly. So that is the table height we are going to adjust. It's not a fixed one, but depend on your height, your elbows should be able to work in between 90 to 120 degrees. And head low position. So head low position is to move the bowel away, because we don't do packing or any other thing to keep the bowel away. So it's the gravity effect. You are keeping your small bowel away. And so head low should be done very well. Otherwise, it is always disturbing your operating field, and it is a risk because bowel can damage, and also it's disturbing your operation field. And also, of course, we need assistance. One doctor assistant usually according to in our country, and also nurse assistant. And sometimes, if you need the help, if you are taking the vaginal manipulation from the vaginal end, you need other third assistant as well. So we should be ready with our instruments or equipments. So these are the list of instruments, equipments. I put in a list. So it's a 5mm telescope with 30-degree tip, because it is one of the most comfortable telescope, and with the 30-degree camera. And also we need at least 5mm ports, four ports in number, and one for the camera, and other 3 for the other instrument. And at least you need 3 tooth graspers. Single action graspers are fine, and also 1 scissor, and 2 myoma screw, if you are using the myoma screw for uterine manipulation. And also uterine, if not, if you are using uterine manipulator, so one uterine manipulator is fine. And so you need kind of energy source, something like advanced bipolar, or else with that you might have other kind of advanced energy source, something like harmonic, where you use ultrasonic energy, ligashua, where you use bipolar energy, and also thunderbeat, which is a hybrid energy where you use bipolar and ultrasonic. So that depends on actually your experience. So finally, once you are done with about 100 laparoscopic hysterectomies, so of course this instrument is not going to matter. So even the advanced bipolar and scissor is fine to do a hysterectomy. And tenaculum, so specimen retrieval through the vaginal end, and also then we need to suture needle holders and suture material suitable, something like barb suture or polygrafting sutures. And we need suction irrigation system to finally wash the pelvic cavity. And also a few additional equipment sometimes we need in difficult situations, where if you think that bleeding is not under good control, so you need to inject vasopressin. So you need needle and the vasopressin, and also mosilator if you are struggling with taking out the specimen. Next, I will go through about few common laparoscopic instruments. One is ligashua. So ligashua is the instrument where you use bipolar energy for sealing of the vessels, and also you cut mechanically once you done the sealing. So it is good to seal up to 7mm diameter blood vessels. So it's a good instrument. So if you can get the grip tissue in between your jaws, so that is better to seal and cut. So that is the ligashua, and easy to use, very easy to use. There's no much settings. Once you connect it, it's working. So it's one of the good instrument. This is the harmonic. You need to set it in, and where you use ultrasonic energy, high vibrating in high frequency ultrasonic energy. So this is another good instrument. So it cut and seal by vibration. So lateral damage is minimal, and it also can be used for sealing and cutting vessels up to 7mm with minimal lateral damage. And very good thing over this one is we can cut and seal in one go. So this is best in laparoscopic hysterectomy at the vault, where you slice your cervix around the cervix and put off the vaginal cuff down. So it's a very good instrument. So in one go, you don't need to seal and cut separately. So it's cutting and sealing at the same time. So that is harmonic. The next instrument is the thunderbeat. So it's a hybrid one actually. Hybrid mean it uses bipolar energy as well as ultrasonic energy. So this is a hybrid instrument, again, very good one. And again, same as harmonic. So though the technology is different, so it is also one go sealing and cutting. Again, in hysterectomy, this ideal to get the cervical cuff from the vaginal cuff from the cervix. So I didn't mean that it's not good to cut other areas. So it's again good. And but when you are using bipolar, it's when you are go around the vagina, so it's a bit difficult to lot of inserts and taking out and reinserting instrument. So bipolar coagulation and cutting separately, but this instrument we can use in one go. So very comfortable and very convenient. Right, now we have done patient preparation. So team is ready. We have selected the proper patient and instrument are ready. Everything fine. Now we are going go ahead with the proper total laparoscopic hysterectomy. So the patient preparation, as I mentioned earlier, it is same as for a general gynecological surgery. And you may give something like Dalcolex just if the rectum is loaded to release. Otherwise, the preparation is not much different. And positioning, of course, different. So this is the after anesthesia, you are positioning the patient. So the patient should bring to the bottom end, and legs should put on stirrups and legs bit up separated. If the third assistant is coming from the vaginal end, so they easily can access through the vagina for the uterine manipulation. And so once we are inside, we are doing this. So we have cleaned and dressed the patient, and the bottom end of the bed we can use with the clean towel to keep the instrument. And this is the this how we put the head low as much as we can, as much as possible, because we should liaise with our anesthetic team. For the anesthesia, of course, there should be experienced anesthetists for the laparoscopic surgeries. If duty anesthetist is there, sometimes they are a bit scared to go head down too much. So in that case, we need to talk to them. And of course, there's no problem with the head low position. We are doing this surgery each and every hour theater days. So this much of head low can go at this position. Your bowel is not anymore disturbing your pelvis. So operating area is completely clear. So you don't need additional assistance to keep bowels away. So it's a good head low is cleaning our surgical area very well. So to go head low this much, you might need shoulder support. So if you can give shoulder support for both sides, so it will prevent your patient slipping by any chance. So there are shoulder supports you can fix to your patient's shoulder. So like this, you can fix it bilaterally. So it will make sure that patient is 100% safe, and we can really do the surgery without any disturbance from the bowel. Meantime, we need to check, once you go in, we need to check around the abdominal cavity. We have to look for whether stomach is distended or not, and also bowel is distended or not. So if those stomach is distended and bowels distended, we can ask anesthetist to put the NG tube and we can collapse them. So then it will be much easier, and so our bowel handling must be very comfortable for the surgery. So these are the myoma screws which we use for the surgeries. Actually, Dr. Modi and myself, we both are doing the hysterectomy in the same way. So these are the myoma screws, very strong ones we have. And if we are not using uterine manipulator, this is the one we use for uterine manipulation. So these myoma screws are very strong, and we can give good stretch towards the head end of the abdominal cavity, because we can pull with levering action. We can shift the uterus to side and also push upwards with the strong action of the myoma screw. So this myoma screw also very strong ones. So that is much more comfortable in total laparoscopic hysterectomy. It will stretch the tissues very well. So then we can easily do laparoscopic hysterectomy. So if you are doing, if you are going with the uterine manipulator, the third assistant should push the uterus up as well as front and back with your myoma screw. But sometimes when the uterus is too big, there are some difficulties in doing that. So my experience, to me, I feel that is a bit difficult than the using the myoma screw. So this is the entry, abdominal entry and trocar placement. So according to your experience, you can use varus needle or direct entry. So in my case, I go with the direct entry always. I use 5mm port with sharp tip. So you make a small incision supraumbilical, and that cut just enough to pass the 5mm one. Otherwise, uh, it will create gas leak later. So you lift in a umbilical grip as much as possible, and go straight firmly. And so it will take only 20 seconds. So I have done this technique with 5mm trocar for about 2000 surgeries. So fortunately, I didn't have any bowel damage up to now. And so it clearly directly go into the cavity. So only thing is you need to pull your abdominal wall as much as you can, and you have to go perpendicular to the stretch abdomen. So then bowel damage chance is minimal. Other thing with that direct technique with the sharp tip, it won't create peritoneal gas leak. So when you are using varus needle, so if you partially entered into the cavity but not pierce the peritoneal cavity, so you may collect gas just outside the peritoneum. So if collection is gone, so it will strip from the abdominal wall, and the large gas collection will come. Then it will be difficult to enter through either through the varus needle or through the direct entry techniques. In that case, you have to take a separate entry point and go ahead and look at the your strip peritoneal area and manage accordingly. So direct technique is one of the best, I feel, and it's easy, and you don't need much strong hands when you are using it. 5mm trocar with sharp tip. So these are the other ports. So after, once you are in with your main port and the camera is in, always you can guide other ports. So this is the first ancillary port, 2 centimeters above and medial to the anterior superior iliac spine. Again, 5mm cut, not more than that. And you can visualize from the inner view. So avoid blood vessels with transillumination if the abdominal wall is not that thick. So always you can use 5mm port, and under direct vision you can go ahead. And the second port is in the left side at the level of umbilicus, and also in line with mid clavicular line. So the first port, second port, and third port will be same in the opposite side. So then we are ready with our port placement. So we have camera port, the main one, and also 3 other ports for the instrument. So this is the use of third degree camera. So I said, so it's a 0 degree or third degree as you prefer. There are 2 groups of people who prefer 0 degree, and some people prefer 30 degree. So I feel 30 degree is better because we can flash light from various directions, from the sides, from the front, from the back. So any direction you can flash light straight away. But I think the 0 degree one, only one direction we can use. So 0 degree camera, 30 degree camera is much more comfortable if you are used to use it. So this is the final port placement, and also the use of the camera. So when the light source is up, so we are flashing light from the top to bottom. So like that. So this is a way of using the third degree camera. So now after evaluating the abdomen, once you go in, you need to go roll abdomen and everything fine, bowel is away. Now, good stretch from the myoma screw. Now we are ready to go ahead with the hysterectomy. So this is the anatomy relevant you need to know. So this is the cornwall structures about the corner of the uterus. So it has two blood supply, one from ovarian ligament, and it comes from through the suspensory ligament of the ovary, and it gives the tube band ovary, and also uterine artery as the first branch of internal iliac artery, and ascending artery comes in the lateral surface of the uterus and anastomose. So this area is the area where we are going to cut at the cornwall structures cutting. So when you go to the proper surgery, so where we are doing excision of the cornwall structures, so we have to stretch the uterus to the opposite direction with the help of the myoma screw. So it's doing it very well. And you coagulate the structures. Whatever press come, you can do it, coagulate and cut. So always give full length of the forceps and coagulate it and seal it and cut half of it. And again, cut the half and again give full length of coagulation and seal it, cut half. The thing is, you should not allow to bleed even a drop of blood, because it will make our surgical site spoil, and you cannot go comfortably. So always in laparoscopic surgery, there's no method for suction or mopping or anything. So the thing is, we should coagulate everything, and we should not allow even a drop of blood to drop into the field. Otherwise, it's going to be a difficult task when the area is covered with blood. So next step, so excision of the posterior leaf of the broad ligament and uterosacral ligament. So this is the next step. So I'm describing here very simple, straightforward hysterectomy, because I want to describe the basic steps. So here I'm using the bipolar and the scissor. So very simple instrument. So what I do is the thing called ironing. So you iron the posterior leaf of the broad ligament and seal it off completely from blood vessels and cut it. So the posterior leaf of the broad ligament up to the bilateral uterosacral ligament. So then you are releasing your uterus from the bilateral uterosacral ligaments. Then it will make lifting up of the uterus very easy. So it is the next step what we are doing, posterior leaf of the broad ligament and the uterosacals. So as the next step, so we can go to the other side. So anterior leaf of the broad ligament. So again, same technique. So just ironing with the bipolar and cutting. So if you are using harmonic or thunderbeat or ligature, you can do it in one step. And I am demonstrating here the lateral entry technique. So bladder is, I'm reaching the bladder bed with the lateral entry technique. So you don't need to go from the lateral entry. So you can go either through the lateral entry, or otherwise you can lift vesicouterine fold and enter into the vesicouterine space. So this is the vesicouterine space. So you are just cutting all the areolar tissue and pushing the bladder down with the bladder pillars. And once you complete it, so you have reached the lower margin of the cervix. So even minor bleeder should be diathermized and sealed off. So bladder is now completely clear, and we have reached up to the lower margin. So this is the picture. So very clear dissection. So we are safe from the bowel damage because it has gone down completely. So the next step is taking the uterine vessels. So this is the place we need to concentrate now. The uterine arteries come to the uterus, and the main vessel goes as the ascending branch in the lateral side of the uterus from the uterine body, from the junction of uterine body and the cervix. So the most important vessel in laparoscopic hysterectomy. This is the vessel. So this is the area. Now, once you done the cleaning part, anterior surface and the posterior surface of the broad ligament, now uterine artery and vein is open. So you can give good coagulation with uterine pedicle, about 2 centimeter length is recommended. And so you can use bipolar diathermy. So I always use bipolar diathermy because I feel it's more powerful and more comfortable. So once you complete the sealing part, you can cut it. You can see the uterine artery here and also uterine vein here. Once you cut, so this is the uterine vein and the artery. So, and always once you cut, give another bus to seal the both ends of the pedicle. So it will prevent retrograde blood flow as well as active blood flow from the lateral sides. So this is the uterine pedicle. So we are taking it completely, and you have to go up to the margin of cervical stroma, so lateral margin of the proper cervix. Next, we have to go down. So this is the area we are going to deal with. So that is the vaginal attachment to the cervix. So the vaginal artery branches are there, and also few branches from the uterine which are coming as descending arteries from the uterine artery. So we can exercise cardinal ligament, and also we can go anteriorly and posteriorly. The cardinal extension of cardinal ligament. So now we should cut the cervix. We have to flush through the cervix. We have to go along the cervix down, and we have to slice the cervix in the outer margin of the uterine tissue, cervical tissue. So this whitish tissue indicate we are not in laterally, we are just going outer margin of the cervical stromal tissue. That's why there are no bleeding, because no much blood supply to the cervical stromal tissue. The blood supply is going in the outside surface. So that's why this whitish tissue is coming out, because we are just slicing of the outer margin of the cervix. So with the instrument which can do coagulation and cutting in the one go, like harmonic and thunderbeat, we can do this in this way. It's very comfortable. You are going posteriorly as well as anteriorly, and then you are releasing the cardinal ligaments and the vaginal cuff from the cervical attachment. Right. Once you've done it, and then you have to go to the other side, and you have to come from the same way, corneal structures, uterine and uterine pedicles and the cardinal ligament, and come to the same step as we did other side. Now you are ready for colpotomy. So open into the vagina posteriorly. It's always safe. There's no bladder, nothing. So you can see bowel down. So at this place, now we are far away from the ureter. We don't need to worry about the ureters, because once we stretch up, our ureters are somewhere here, and we are pushing the uterus up. So it is keeping a very good gap, maybe about 4-5 centimeters gap from the ureters. So we don't need to worry about the ureter. Bladder is in the other side. We can go easily with the colpotomy. So again, some instrument like harmonic or thunderbeat is doing very well. So we are just slicing outer surface of the cervix, and we are just opening into the vaginal opening there, vaginal end. So once you enter into the vagina, you can go around under direct vision and separate the vaginal margin completely from the vaginal margin completely from the cervix. So go around under direct vision. You can see bladder is far away, ureters are far away. Uterus is well stretched upwards, and so there's no risk for any damage to the ureters or the bladder. So we are far away from those structures, vital structures. Now you are completely taking out the uterus. You can see the cervix is complete, and there's no involvement of the scomocolumnar junction. So we are very safe. And also now we have separated it. So if you are doing oophorectomy, this stage we have to do self-oophorectomy, otherwise at least self-injectomy. So we have done the hysterectomy part. Now as the next step, we need to take out the specimen. So we should take out all the tubes or the ovaries, so like that. So you can use valsalva or any other tenaculum and take out the specimen through the vaginal route. And if the specimen is so big, we have to struggle either to mosylate or cut into pieces or bisect the uterus and take out again from the vaginal route. So that's why I said for the beginners, always start with the simple cases where you are not struggling to take the specimen out. So if you are selecting about 10-week size uterus or 8-week size uterus, specimen taking out through the vagina is not that difficult process. So once you've done it, so everything done. So if the area is not clean, you can have a good wash and start suturing. But if the area is not that disturbed much, if the vaginal cuff is clear, you can start straight away suturing. So this is suturing with this one with barb suture. So we have to take the vaginal margin very clearly and not include the bladder. And also, if you want, we can catch the uterosacral ligament, and uterosacral ligament can be fixed to the vaginal cuff to prevent the future wall collapse. So, so needle holders, you have to practice the use of needle holders. So you needle holder and the helper grasper. So you have to go on suturing. So either continuous suturing with barb suture or you can use Vicryl or something with interrupted suturing and with securing the both vaginal ends very well. So suturing, and we are closing the vaginal cup. So if as there are no bleeding, so you don't need to tight the sutures very much. So just approximation is enough. Once you've done it, the final step. So we have done the suturing now, though there are no much bleeding. Next step is final inspection for bleeders. We have to wash and clean, and we have to close the abdominal incisions. If you use the one port for the mosylation for the hysterectomy, because the uterus is big and so we need to mosylate, we have to use the port closure. Otherwise, this is the final appearance of closing the abdominal, all the small incisions. Finally, I would like to thank my trainer and Dr. Rajesh Modi. He's helping me a lot since 2016, and he's my mentor. Thank you very much, sir. And also the president and the council of the SLCOG, and all the speakers today and the panelists in the webinar today, and my teachers, colleagues, and trainees, and all the participants. Thank you very much.
Sir. Okay, thank you very much, Kumar. I think that was a very comprehensive presentation. And I think everybody got a very good idea about the basic steps in laparoscopic hysterectomy. And our next speaker, Dr. Rajesh Modi, I think he doesn't need much of an introduction because he is very familiar to all the consultants from Sri Lanka. And I'm also one of the trainees. And okay, he has his own technique of laparoscopic myomectomy, this aqua dissection technique, and then he's very experienced in laparoscopic hysterectomy and laparoscopic tubal recanalization. And again, he has his own techniques. And Dr. Modi's signature needle holders for lap suturing is another very fantastic thing. So we experience. And he has so many fellowships, and he's conducting so many courses, short courses for gynecological endoscopy, and then for last 12 years. And so Dr. Modi, and again, he's a vice president, Foxy 2017. And over to you, Dr. Modi.
Thank you very much, Dr. Mangala, for the kind introduction. It's really a pleasure to get back to all of you and to interact with you all. I also take the opportunity to welcome Dr. Mete Gungor from Istanbul, Turkey. Thank you, Dr. Mete, for sparing your time to be with us. I would now like to go ahead with my lecture. I'm going to be talking about some particular steps of hysterectomy, which I particularly like to promote. Hysterectomy is one of the commonest benign gynecological endoscopic surgeries being performed everywhere. So from my perspective, there are a few things which I would like to highlight in today's lecture. Dr. Kumar has given an extensive description of the basic steps right from the time of beginning of the hysterectomy, from the corneals to the wall suturing. And more or less, the steps remain the same for all hysterectomies, irrespective of the size of the uterus, the size of the fibroid, or the adhesions which might be present. So there are few points again, which I am going to highlight as my particular steps. So here you can see that I use a myoma screw to manipulate the uterus. The main difference in the use of the myoma screw is you need to be able to lift the uterus up. Don't pull on the uterus like this. Lift the uterus up. The concept is very simple. You have to lever the uterus up so that the myoma screw will not avulse again and again. So if you're pulling in line with the trocar, the chances of avulsion of the myoma screw and then bleeding from the myoma point are high. But if you lift the uterus up as a lever, then you can manipulate the uterus much better. And because of the spirals of the myoma screw, the screw does not get released from its hold and you do not encounter excessive bleeding during the surgery. Now, in case of a large fibroid uterus, maybe 22-week or 20-week size, there are always steps where you have to advance the myoma screw. So I find that myoma screw for manipulation allows you the best and optimal traction. Good traction is an important point for a good hysterectomy. Now, the myoma screw you can see in this particular case, initially it comes from the right side of the patient when I am operating on the left half of the uterus, and then when I am operating on right half of the uterus, the myoma is coming, the screw is coming from the left side. I am standing on the left, so I pull on the myoma screw, give good traction, and then we have a good amount of leverage available. Concept remains the same. The carry home point in this particular video is don't pull on the myoma screw, lift the myoma screw. So if you're not pulling on the myoma screw and you lift the myoma screw, there is no avulsion, no bleeding, and the surgery goes much more comfortably. Now, even in a size like this, a huge lower segment fibroid with a small uterus sitting on top, manipulation becomes convenient and easy with a myoma screw. For this kind of a uterus, probably a vaginal manipulator may not be effective. And when you are going a little close to the corneal structures or lateral wall structures, you can always advance the myoma screw. So here you can see that we do not have adequate traction right now because from the cornea to almost the lateral pelvic wall, the dissection has been done. So I need to step it forward. Compared to the location where we put it, in a bulky uterus or a 12-week size uterus, in a larger uterus, this becomes convenient and easy that you remove the myoma screw. And when you remove the myoma screw, you can use a bipolar so that the backflow from the uterus is not significant and not collected too much into the upper part of the abdominal cavity. That much wash will be required otherwise at the end of the procedure. Now here you can see that we are now advancing the myoma screw, going down on the anterior large fibroid, placing the myoma screw close to the field of surgery. So where do you need to put the myoma screw if you're advancing? The simplest principle is place the myoma screw close to the field of surgery and then give traction. Now you can suddenly see that the amount of traction now available has changed drastically. Significant traction is now available from the uterus towards the lateral pelvic wall. And this becomes easy to operate. So not only for large uteri, I have gotten into a habit of using the myoma screw for almost every surgery. For a bulky uterus also, we use a myoma screw and manipulate the uterus. Good traction is extremely important when you want to stay in the correct planes. Half of the surgery gets done simply because you are in the correct planes. There is no bleeding, no oozing, and the tissues respond very nicely. The next step is what I again want to highlight is about the bladder dissection. The UV fold is easily identifiable with the capillaries which are present on the bladder serosa as compared to less or no capillaries present on the uterine serosa. We use the bipolar to coagulate and then use the scissor to cut. Now here, when you are using the bipolar, make sure that you push the foot switch in a short burst. Do not push the foot switch for a long duration, because the heat transmission to the lateral side is more if the foot switch is pressed for a longer duration. There is not much of bleeding which happens from the UV fold. So you don't really need to use too much of cautery in this area, but so that we have a clean and a bloodless feel when we are operating and dissecting the bladder, it is preferable to have a certain amount of coagulation. Now, once you have cut the UV fold from left to right, again, single important point here is very good traction being exerted on the uterus, pulling the uterus out of the pelvic cavity. And then with good traction, all you need to do is lift the UV fold. Don't directly try to push the UV fold down. Lift. The moment you lift the UV fold, you can see the areolar tissue. And when you can see the areolar tissue, it becomes easy for you to push the areolar tissue down. The scissor is being used to lift the UV fold. It is just hooking the UV fold up. There is nothing to be cutting it over there. And then when we push, it goes down in the correct plane. If you are in the correct plane, you will not avulse the small veins which are there in the bladder area. So this is why I meant that good traction allows you to be in the correct plane, and half of your surgery gets done because you are in the correct plane. So this is the bladder which has gone down. Now this was a simple case where the bladder has been pushed down, which is without any previous cesarean, without any previous scarring. And in all these cases, areolar tissues are much more cooperative than routine. There are also cases where you have previous cesarean and the bladder is slightly adherent to the cervix, or there are some cases where the bladder may be very densely adherent to the cervix. There are still some fibers you can see on the bladder pillar area over here, which we are separating right now. So bladder has gone down in the center. Areolar tissue has allowed us to dissect in the correct plane. Key factor has been good traction, which has been exerted by lifting the uterus up with the myoma screw. Now, this particular case is having a bladder which is adherent. Now, here you can see that previous one cesarean is there. Not significant adhesion, but the concept of bladder dissection will remain the same. You cut from left to right. Nowadays, I don't use bipolar and scissor for the last almost 5 to 6 years. I have started using Thunderbeat for my routine hysterectomies. The first case I showed you for the sake of simple dissection. Now the same concept of left to right, the UV fold is being cut with a Thunderbeat. The Thunderbeat allows us to use minimal thermal energy, more of ultrasonic energy, and then it allows us to cut without having much of bleeding coming up. Now, because this is a previous cesarean patient, you need to go a little lower down with the sharp dissection. So again, from left to right, I am going to be cutting the tissue. This is slightly adherent tissue. Even if you try to lift the UV fold up, you're not going to encounter the areolar tissue as you did with a simple case. So in this case, till the time that the areolar tissue identifies itself, you need to be able to use sharp dissection. So twice or thrice, we go from left to right, cutting off the fibrous bands in case of a previous cesarean. So again, now from left to right, same steps are getting repeated as what we did when I was cutting the UV fold. So this is the UV fold getting separated. From left to right. 2 or 3 times. You may need to go again and again from left to right 2 or 3 times, but that does not create any problem. Once you see the areolar tissue as you are seeing over here, then it becomes almost similar to the previous case, that you lift the UV fold and then simply push the areolar tissue down. The vertical running vessels also indicate that you are in the correct plane. So the UV fold was separated. Again, 1 or 2 layers of fibrous tissue have to be separated. And just below the area where the uterine scar is, you will find the vertical running vessels. When you see these vertical running vessels, you lift the UV fold, see the areolar tissue, and simply push the areolar tissue down. Don't try to push the bladder down. The areolar tissue is being pushed on the cervix. So flush to the cervix, you are pushing the tissue down. The bladder is being lifted up with the grasper. There is no hesitation in lifting the bladder by holding it firmly with a grasper. It's an atraumatic grasper, so do not be worried that you're going to crush the bladder or cause a traumatic injury to the bladder. But this is the simpler way of getting into the correct plane. Again, even in a case like this, good traction with a myoma screw is absolutely essential. How much lower down to go? You have to be able to see the uterine knuckle clearly. That is how you identify that you have gone down enough. Now, in some situations where you feel that the bladder is very badly plastered, we dissect what is called as a lateral window. In this particular case, the bladder is not very badly adherent, but this is just for demonstration of how to get the lateral window. So here you see the bipolar tip has changed from a normal fenestrated to a Maryland type. The purpose being, smaller the tip, smaller the tissue which is going to get coagulated, lesser chances of damaging to the bladder. So initial step remains the same. You have to go from left to the right, cut the UV fold once so that the UV fold gets dragged down with the traction. Unless you do this, you will not know whether the bladder is very badly plastered or not. Now, when you come to a stage where you find that the bladder seems to be buried into the scar or quite densely plastered, there is no need to do the lateral window technique. So this is from left to right, UV fold is released. So what exactly is the lateral window? Between the uterine knuckle, the cervix, and the bladder, there is a space which is called as Shade's space, and that is what we try to dissect. So what we are trying to do is we are going to go into the space below the scar between the bladder and the cervix. So we lift the bladder up, bypassing the scar. So this is on the uterine side, between the uterine, the cervix, and the bladder. So the bladder may be adherent in the center on the cervix, but next to the uterine, because of the pulsations of the uterines, there is a significant amount of areolar tissue always present over there. Now, when you have areolar tissue present, areolar tissue is surgeon-friendly tissue. It allows you to get into the correct planes. Now you can see some part of the uterine coming up over there. The fat belongs to the bladder. So fat has to be lifted up. The fat belongs to the bladder. The fat part has to be lifted up. And just below the fat part is the window. So traction has to be good. Position the 30-degree scope in such a way that you are looking down onto the fat part. That is the uterine. You can see the uterine bulge. So between the uterine bulge and the yellow part is the window. So all I need to do is tease the yellow fat part up and the uterine part down. Now keep the scissor closed and use the same scissor and the dissector. Gently teasing the tissues. Gently tease the tissues. The uterine artery, though it appears like a vascular structure, it is quite strong. It is unlikely that you will ever avulse the uterine artery itself. The yellow part needs to be lifted away from the uterine. So very clearly you can see the yellow part here. Teasing the tissues, and if there are small oozes, the Maryland tip allows you to coagulate without causing too much of ischemic trauma to the bladder tissue over here. Now you can see some sort of cervical area coming up. Again, turning the 30° a little bit more. We have to lift the bladder up from the cervix. So the bladder means the yellow part. The yellow part needs to be simply lifted up. This is what we call as a lateral window technique, which is to be used in cases where you really find that the bladder is not cooperating when you are trying to dissect the bladder down, and you still need to go ahead and finish the hysterectomy. So that is the complete lateral window which has been opened up over here. So here you can see anteriorly the yellow part of the bladder has been lifted up. On the lower side is a cervix, and on the outer side is the uterine. So what we have done is just between the uterine, cervix and the bladder, we have teased the tissue. That's all. And very comfortably it gets dissected away. There is usually not much of a bleeding or oozing in this area. And we are doing it with a bipolar so that in case of any small oozing that you might encounter, you can cauterize it without much of a hesitation. So what is the main advantage of having dissected this? Now you know the extent to which the bladder is adherent into the scar area. Now, when you know the extent to which the bladder is adherent, you can always cut a little into the scar tissue. At the expense of the scar tissue, you can separate the bladder from the adhesion. So here again, I'm using some part of bipolar. In this particular case, as I had mentioned, the bladder is not very badly plastered, but this is the main advantage. Doing the lateral window dissection technique does not actually mean that you are dissecting the bladder away. You are only lifting the part which is bypassing the scar so that you know how much of the width of the scar you need to separate. And once you are able to have that confidence, then your surgery goes much more smoothly. So the lateral window technique does come in handy, especially when you are lost as far as the plane of bladder dissection is concerned in previous cesarean, when you go directly in the midline. So this is from left to right. We have separated the entire scar area and the bladder has gone down comfortably. Normally speaking, if these are previous cesarean, as I showed you in the previous surgery, you can simply use from left to right, 1 layer, 2 layer, 3 layer, and the bladder cooperates and goes away. But rarely in the beginning, when we separate the UE fold and you feel that the bladder seems to be buried a little deeper inside, then you are concerned and you would like to probably change your technique. Now, the next step to this, what comes is the uterine dissection. So now these are the same 3 surgeries I'm going to repeat over here, which we have shown for the bladder dissection. So here, the difference in my technique when I am doing a hysterectomy is I have a habit of isolating the uterine vessel simply by pushing the bladder pillar down. The single step which is different in what I am following is that once the bladder has been dissected down, we don't simply try to go for the uterine. We try to push the bladder pillar down. So now this is enough for a routine hysterectomy. This is the uterine knuckle part. The bladder seems to have gone down quite well. This is the UE fold. This is the knuckle part. And this is okay for a routine hysterectomy. You can coagulate and cut off the uterine at this particular step without any difficulty, without any complication, without any problem. But like I mentioned, the yellow part in the front is the bladder pillar area. And what I have a habit of is dissect the pillar down. Now, once you have this habit of dissecting the pillar down, you see what is called as the transverse segment of the uterine vessel. So this is the transverse part of the uterine, which is from the lateral pelvic wall up to the cervical area. And above this transverse part, this is what is called as a bladder pillar area. So bladder pillar will have slightly more amount of small vessels. So we do end up coagulating a little bit more over here and then releasing the bladder pillar point. So releasing the bladder pillar allows the uterine to be exposed right from the lateral pelvic wall up to the cervix, not only the ascending and the knuckle part, plus the bladder has gone down significantly. It allows you to coagulate and cut off the uterine without the fear of having any bleeding. Plus, in case of having excessive coagulation done, you still have the bladder which is significantly fallen down. So posteriorly, the uterosacral has been released. Now, anteriorly, the bladder pillar has been pushed down. Posteriorly, the uterosacral has been pushed down. This is what we label as skeletonizing the uterines. Upper point, this is the ascending branch. And this is the transverse part. The transverse part is what we always try to see and then finish the hysterectomy. The further dissection which I am doing now is not done as a routine. This is just to make you see the pulsations more clearly. The further skeletonization of the uterine artery and the vein separate is not done by me on every routine hysterectomy or every routine case. This is just for the sake of the lecture and the demonstration part. This is the transverse part of the uterine. Now, below the transverse part of the uterine is the ureter. So we will never coagulate the transverse part. We will only coagulate where the UV fold has been cut. The landmark is where the UV fold has been cut is where the uterine has to be cut off. 1 centimeter above that and 1.5 centimeter below that, coagulation of the uterines is sufficient. Do not coagulate the exposed transverse part of the uterine simply because it is not required. And below the transverse part is what I mentioned is the ureter. So unnecessarily, we will not want to go and have the heat getting transmitted towards the ureter. What we are coagulating is at the level of the isthmus or where the UV fold has been cut is the level where the uterine has to be cut. Now here also you can see the same step is getting repeated onto the other side. So bladder pillar area. This is the bladder pillar area which is being coagulated and teased down. So from both the sides, the steps remain the same. On the right-hand side, the side which I am doing right now, it's mainly with a bipolar and a little more blunt dissection because here I'm having only one instrument inside. The yellow part is the bladder pillar part. So the yellow part needs to be coagulated and teased lower down. Once you have the yellow part which has gone down from the transverse segment, the isolation of the transverse segment becomes much more simpler. Now you can see that the uterine is beginning to identify itself. That is the transverse part. And this is the knuckle part. So the knuckle part is what we are going to coagulate. And the transverse part is just for the sake of exposure of the transverse part, which becomes a backup to coagulate in case there is any bleeding which cannot be handled. The knuckle part, or again, to repeat, where the UV fold has been cut off or where the isthmus of the uterus is where we are going to cut off the uterine. The lower section is just exposed for the sake of doing a clean dissection and to have a clean hysterectomy for every single case. If you have done this dissection for maybe 10, 20 cases, then you become habituated to this particular dissection and every single hysterectomy becomes absolutely safe and comfortable. Same technique now with a thunder beat. Like I had mentioned that initially I was using bipolar and scissor, but now of since last 5 to 6 years, I'm comfortable with ultrasonic energy. Either you can use a harmonic or you can use a thunder beat. The same concept remains there. The uterine is exposed. You can coagulate and cut off over here. Anteriorly, the pillar has gone down. Posteriorly, the broad ligament has been pushed down, but the pillar has not been pushed down over here. So if you want to be much more confident about every hysterectomy that you do, you need to be able to lift the pillar up. It is simple. It is not very difficult, and there is usually not much of a bleeding in the area in your learning curve also. You need to tease the fat away from the uterine. You can see that the fat is being lifted up, and then I am teasing the tissues gently with the instrument. Don't overcoagulate in this area because this is the transverse part of the uterine, and below the transverse part, the ureter will be there. So do not overcoagulate. In case it oozes a little bit, it will only be a venous ooze, so you can definitely ignore it. There is no hesitation, there is no problem in ignoring it. Previous multiple cesareans, sometimes there is fibrosis in the knuckle area because of probably sutures being taken to ligate the uterine angle if there has been bleeding. But there will always be a nice areolar tissue gap available between the pillar and the uterine area, the vessel. So this you can see that the uterine vessel is now coming up. This is out of habit. It is not compulsory that you have to do this dissection. It is not mandatory that you have to be able to identify the knuckle for every case. But the transverse part, sorry, not the knuckle, the transverse part. But to be able to dissect the uterine gives you the ability to be confident about your hysterectomy and its outcome. So now you can see when we allow the uterine to fall back into the pelvic area, that is actually the transverse part of the uterine, which you can see over here. So this is from the lateral pelvic wall up to the cervix. Again, a similar case over here where we had done the dissection of the bladder, the lateral window. So the lateral window has been separated, the bladder has been pushed down, posteriorly the broad ligament has been pushed down. But still, this is not the standard dissection which I do. I am more confident and comfortable once I have dissected the uterine transverse part. So we need to go one step lower down. So this is the change in the dissection which I do compared to other people doing the hysterectomy, that we spend another 10-15 minutes to dissect the bladder pillar down a little bit more so that the transverse part of the uterine gets exposed and remains in the front. Once you are habituated to it, it will take hardly 5 to 7 minutes extra in every case. So it is a matter of developing it as a step of hysterectomy. Bladder pillar is gone down. I am pushing the yellow part of the bladder pillar more here. You can see the uterine identifying itself. Teasing the tissue is something which you should be able to develop. You need to be able to manage skillful handling of the tips of your instruments. The yellow part belongs to the bladder pillar. So the yellow part needs to be lifted away from the vessel. This is the pillar being pushed away from the transverse part of the uterine. So now you have the entire transverse part seen in the front. This is the transverse part. You allow the uterus to fall down into the pelvic area, and then you realize that that actually becomes a transverse pulsation, and below the transverse pulsation, you may see the peristalsis of the ureter. So here you may not see the pulsations, but here in this particular case, what we have done is we have used the infrared system. This is a Striker 1588 camera, which we use sometimes. The ureter is catheterized and the infrared glow is read by the camera. The uterosacral being released from the posterior part allows the ureter to fall lateral when we are operating. So that itself also makes a difference when I am dissecting. Having pushed the uterosacral back allows the ureter to fall back. And then when you dissect the transverse part of the uterine, because the traction is good, the uterus is lifted out of the pelvis, the transverse part of the uterine appears to be vertical. So here you can see I am lifting the uterine artery and dissecting it. And when you allow the uterus to relax, you can see water flows under the bridge. You can see that the transverse part of the uterine is just on the ureter. And then when you give a good traction, The transverse part gets lifted up, the ureter does not get lifted up. The ureter stays on the lateral pelvic wall. So giving a good traction allows you to operate in a correct plane, thereby reducing the blood loss. Plus, it allows you to become safer in your surgical outcome. So these are the steps for the uterine dissection which I wanted to highlight. So this is one of the key factors which has allowed me to have a hysterectomy done for any sort of a uterus without any significant hemorrhage or bleeding coming up. Plus the concept that I have the uterines managed very well. The transverse part is also visible, allows me to have the confidence of being able to send the patients home in the evening. As I had mentioned earlier that we do have daycare hysterectomy for all our patients since almost 20 years now. So morning we admit, we do the hysterectomy, maybe in 3 or 4 hours, the patient is able to walk around in the hospital. Evening 5:30 p.m., we allow the patient to be discharged and to go home. So this daycare hysterectomy comes with the concept that I have the confidence that the hemostasis from the uterines is perfect and it is not going to end up bleeding at any time. The last part which I just wanted to give a small highlight about is the vault closure. So vault closure can be with anything. It can be either with vicryl or it can be with barb suture. Does not make much of a difference. We usually, nowadays I have started preferring the use of 2-0 vicryl, and we take 2 or 3 interrupted figure of 8 sutures. Here in this particular case, you can see I am using a barb suture for the closure of the vault. Now I have stopped using barb suture because it stays for too long, and whatever ischemic tissue is there at the end of the vault is going to get sloughed out in the 2nd week, 3rd week. And sometimes whenever there is a little more amount of ischemic tissue there which gets sloughed out, if there is an infection, then the patients come back with some amount of spotting or bleeding in the 3rd week of hysterectomy, which we can always maintain very easily with antibiotic cover and control it. But I have had an experience that vicryl 2-0, which we use, tends to disappear a little faster from the vault. The chances of post-hysterectomy leukorrhea is slightly less compared to when I have used the barb suture like this. The barb suture which I use is 4-0. So that gives an advantage that we have a very fine approximation of the vault, but may not be required. I mean, you may not really need cosmetic approximation of the vault. So 4-0 becomes a little too fine. I have kept this 4-0 because we sometimes need to suture the bladder if you have opened the bladder. But otherwise, 2-0 vicryl is comfortable for the closure of the vault. And having a good hemostatic end result is what is important for being able to have a pain-free recovery for the patient. So here you can see it is mostly pink areas and very less white areas, which we prefer to have at the end of hysterectomy. In addition to that, there is no active oozing or bleeding at any stage. So vault closure again becomes routine. Kumar has already covered that. One slightly different step which I want to now cover is, this was for the routine surgeries for hysterectomy that we had discussed about bladder dissection, lateral window technique, uterine dissection for all my cases. Now, rarely you come across a situation like this that you have to do a hysterectomy for a frozen pelvis. So if I think Sri Lanka has apparently much more amount of endometriosis than what we get over here in India. So probably you face this situation much more than what we do. Now, when you have a frozen pelvis or patient having been operated for chocolate cystectomy prior, and then you are supposed to do a hysterectomy, you have everything adherent on the pouch side. Inject vasopressin into the uterus. So this is 20 units of vasopressin diluted in 200 ml of normal saline. This is what I am injecting into the uterus. The complete blanching of the uterus means the blood from the uterus has been replaced by the saline, and it will be held in place for about 20-25 minutes. Now, why do I want the blood from the myometrium to be removed? We need to do the dissection of the posterior part of the uterus, and I do not want to use an energy source. So I am going to use only a scissors to dissect the entire bowel from the posterior part of the uterus. When you are trying to dissect the posterior part, 80 to 90% of the oozing comes from the uterus side or the myometrium side. 10 to 15% of the oozing will come from the mesocolon side when you try to push the fat part away. So if I do not have the bleeding from the myometrium side, as you can see in this situation, the dissection of the frozen pelvis goes very smoothly and in the correct plane. The moment there is bleeding, I know that I am cutting into the mesocolon or into the bowel. So I need to go more flush to the uterus. The blanching allows me to stay in the correct plane with less amount of effort, and the surgery goes faster. Now you can see that the bowel part is coming up. The white part on the lower side is the bowel, and the white part on the upper side is the myometrium. But because we have a good camera system, the clear field of vision allows me to progress with the sharp dissection much more confidently. Now, in the same scenario, if you had blood trickling down constantly in your field of surgery, you need to constantly suction out the blood or keep repeatedly giving a wash, which actually takes away the flow of your dissection. So here you can see the bowel is being pushed back. It is quite a badly adherent and plastered bowel because of previous surgery for endometriosis. And this is something which we encounter. If you have a patient who has a history of surgery for chocolate cystectomy or adhesiolysis for endometriosis, this kind of adhesions are expected. There is even some chocolate material coming from inside the myometrium. The chocolate material oozing out from the myometrium is fine, but it is usually the dirty color or the yellowish colored pocket of collection which comes up from the bowel side, which gives you a scare as to what exactly is coming out. I'm advancing the myoma screw on a different location so that we can see the surgical field better. So when you want to advance the myoma screw, the principle is what I had mentioned in the beginning of my lecture, that you have to advance the myoma screw, place it close to the field of surgery. So this area which I need to dissect, the myoma screw is going close to this particular field of surgery. Do not pull on the bowel too much. You do not want to handle the bowel significantly. The traction on the myoma screw is much more better and effective in lifting the uterus up. We are gently providing some counter traction with a grasper. Here I am avoiding opening the grasper, holding the bowel and pulling it away. I'm just using it to try and push it gently away. So do not do bowel handling as much as possible. Where it is required, you can definitely hold it, but otherwise simply go flush to the uterus and keep cutting. Again, to reiterate, because we have injected vasopressin and saline, there is no backflow coming from the uterus. My field of surgery is clean. I'm going to go a little faster in the tissue dissection because of this particular reason. It's a very simple technique. Use saline with vasopressin in the uterus, allow the uterus to have the blood replaced with the saline, and then go with a simple sharp dissection, separating the entire posterior adhesion from the uterine tissue with lesser risk of having damaged the bowel. You obviously still have the same risk here that you may damage the bowel serosa or even the muscularis, but you should be able to visualize it much more easily. The moment you go towards the bowel serosa or muscularis, there will be more oozing in that area, and that makes you go more towards the uterus. Traction plays a key role. Traction plays an important key role in trying to stay in the correct plane. Even in this particular situation, you can see that we are now lifting the uterus up. The traction allows you to go below the adhesion level. The moment you go slightly below the adhesion level, the areolar tissue will again cooperate over here, which allows the bladder's bowel separation to go more smoothly than in the fibrous part. If there is a patient who has not been operated for before, but there are these similar kind of adhesions, those adhesions are less fibrous, and there will always be more of areolar tissue available for me to do the dissection faster and more confidently. Only when there is a previous history of surgery, the fibrous tissue of the bowel is plastered sometimes deeper into the myometrium. Like over here, right now, I am being a little slow. So this is the simple key step I wanted to specifically highlight for frozen pelvis. These are the main 3 points which I wanted to put across in today's lecture, that the dissection of the bladder with the lateral window technique, the dissection of the uterine, pushing the bladder pillar down so that you can visualize the transverse part of the uterine slightly better. And in case of a frozen pelvis, you can do the dissection on the posterior side simply with the use of scissors to be able to push the bladder, to be able to push the bowel away without going too much into the bladder serosa. Just for the sake of identification and to be able to highlight that catheter, I want to run this small video once. So not in all cases, but in the certain difficult situations, having the ureter glow throughout the surgery becomes a little more easy on the surgeon. So here you are doing a cystoscopy. This is a bladder which we are looking inside, and we are passing a catheter inside the ureters. So this is, I'm just showing the infrared system from Stryker. I have to spend 10 to 15 minutes extra for this particular step in a hysterectomy, that I have to pass the catheter in both the ureter. So I do a cystoscopy using the hysteroscope, which we use for tubal cannulation, pass the catheters inside. So this is catheter which will go inside, and inside this we will pass a filament which will have an infrared glow. The 2 mark is a 20 centimeter mark. This is another 2.5. And this is a 3 mark. So 30 centimeter inside. This is sufficient. So up to 30 centimeter length, we have passed the catheter on one side. We are going to use another catheter, go on to the other side. Once both of these catheters are placed, then we use a filament. Now that filament is attached to the same light source which we use for the laparoscopic light. So that is the iris system. The filament is attached and the iris glow is turned on. The infrared light cannot be seen with naked eye, but it can be seen through the telescope and the camera. So you can see the filament which is having an infrared glow. And this we are going to thread inside the catheter which we have placed. So like I mentioned, this is an additional 10-15 minute of surgical step which I have to do over here. This is passing the stent inside the catheter. Now this allows me to identify the ureter. And now, because it has been so many years that I have used the system, understanding where the ureter is has made it easy for me to teach how to do the steps of hysterectomy and to be confident that you are actually quite far away from the ureter in all benign gynaec surgeries. So logically speaking, for a benign gynaec hysterectomy, you should never be worried about the ureter coming into your field of surgery or coming close to your instrument to be cauterized. And this understanding becomes easier with this particular system. So now for myself, as a routine, I don't need the catheter. But when you are in the learning curve, if you have the system, this allows you to understand your own surgical steps in a much more better and an easier way. So throughout the surgery, the glow of the catheter remains there, and you are able to figure out how things are working much more easily. What I had in mind was to be able to stop my lecture now. It's only been 45 minutes instead of 1 hour. But the advantage is, in case at the end of the session we have any questions which need to be answered, the panel will be able to answer additional questions. So if that is okay, I will ask the organizers to conclude my lecture, and we can move ahead either with a question answer session, or we can move ahead with the panel discussion. Thank you for patient listening.
Okay, thank you very much, Dr. Modi. And I think that's also a very comprehensive presentation. I think you shared your experience with us and your expertise with us. And okay, next is our panel discussion. And then we have actually 5 panelists other than the Dr. Modi. And then first one, Professor Meet Ganga. He has graduated from Hysterectomy of University in 1988 and completed his residency in obstetrics and gynecology at Ankara University Hospitals in 1994. And he has worked in Mayo Clinic in 2000 for gynecologic oncology, and he was specialized in gynecologic oncology and advanced laparoscopic and robotic surgery, and including endoscopic cancer surgery, endoscopic resection of deep and rectal endometriosis and large myomectomies. And he's been the chief in obstetrics and gynecology department of Hysterectomy University School of Medicine since 2010, and also the director of minimal invasive robotic surgery and gynecological endoscopy department in Acıbadem Maslak Hospitals in Istanbul, Turkey. And he is also one of the past president of Turkish Society of Minimal Invasive Gynecologic Surgery and the Minimal Invasive Oncologic Surgery, and honorary president of the Society of Robotic Gynecologic Surgery. And our other panelist is Professor Rasika Hera, and from Sri Lanka. He's currently working as a professor and head in the Department of Obstetrics and Gynecology, University of Kelaniya. And he got through his postgraduate MD and part 1 and part 2 with gold medals for best performances. And he was board certified as a specialist in obstetrics and gynecology in 2009. And he was promoted to the position of professor in obstetrics and gynecology in 2019. And he has various research publications, and his research interests are high-risk pregnancy and minimally accessed surgeries. And the next panelist is Professor Nishendra Karunaratne, and he's a consultant gynecologist and obstetrician. And he earned his medical degree from University of Colombo, completing medical internship at Castle Street Hospital for Women and LR Lady Ridgeway Hospital for Children in Colombo. And he received his MS degree from the PJM University of Colombo in 23, and he received his membership from the Royal College in year 25. And currently he is attached to Lanka Hospitals, and he is working as an in-house gynecologist of Fertility Center. And he has a special interest in advanced laparoscopic surgery and subfertility. And he has many awards, and the first one, and he got an award. He awarded SS Ratnam Young Gynecologist Award of Asia AFOG in 29. And the other panelist, Dr. Sampath Gnanaratne, and MBBS, MD, and MRCOG, and he has advanced laparoscopic training in Germany, and the gynecoloscopic special training in India. And he works as a consultant obstetrician and gynecologist in various parts of the country, including in peripheral hospitals. and he is currently working as a senior lecturer of Faculty of Medicine, University of Peradeniya. And the other panelist is Dr. Kumara Disanayaka. And this is, I think, the panel discussion is going to be moderated by Dr. Modi, and it's over to you, Dr. Modi.
Thank you very much. Thank you very much for the same. I welcome all the panelists. Dr. Kumar, nice to have you here with us. Dr. Mehte, welcome again. Dr. Sampath, Dr. Rasika, and Dr. Nishendra. I look forward to having a good discussion with you for the panel discussion. The concept which I am having today is we are planning to discuss only about our practical experiences, about what we do in the OT, how we do it, and what problems you have faced and how you have tackled. This is what we are interested in listening from you today. So as far as hysterectomy complications are concerned, we are supposed to be discussing about preventing and managing the complications. And I would broadly classify them into 4 types. The first and the foremost, or in the beginning when you start doing a laparoscopic hysterectomy, the major concern that you would probably have is about what kind of bleeding are you going to encounter, not only for hysterectomy, for any laparoscopic surgery. Being able to tackle bleeding or to prevent bleeding is a key to be able to do any good laparoscopic surgery. Once you are comfortable with not having bleeding, whether it is a slightly long duration surgery or a short quick surgery, the surgical part becomes much more smooth and easy on the surgeon. Now, coming specifically to the hysterectomy part, we are going to be discussing about bladder, the ureter, and lastly the bowel. So to start off with the bleeding part, the first question which I have for all of you, we will start with Dr. Mehte. What energy source do you use from the concept of preventing bleeding in your own OT, and what are you comfortable with?
To you and all the Sri Lanka Society board members for the invitation. It's my pleasure to participate in this webinar. So for the energy instrument, I generally use Thunderbeat because it's very fast, and also we can use the both dipolar energy and also the ultrasonic energy in the same instrument. And also it has thin tips, so it's very useful for the tissue dissection, especially in the peritoneal area and also the retroperitoneal area, to dissect the lymph nodes also. So we don't need to change the instrument. We can only use this instrument, and we can finish the instrument only by using one energy modality. So I like Thunderbeat, but also I liked Ligasure. If the case is difficult, for example, if I do a large uterus hysterectomy with a large myomas, so the vessels may be larger. So Thunderbeat bipolar energy modality cannot be enough for the close these vessels. So the Ligasure is more useful in this larger vessels in this kind of cases.
Dr. Sampath, has been your experience, and what is it that you prefer to use in your hysterectomies?
Thank you very much for the invitation, and it's a great privilege for me to stay with you, this kind of expert panel. And Dr. Moody, to be honest, I have been using Thunderbeat as well as Dr. Mate said, Ligasure. But sometimes what I feel is, whenever I use Ligasure, sometimes you feel to use the energy device a little bit longer, but the tissue impedance detected by the machine and just stop the further coagulation. But I may be,
No,
need.
Basically, it does happen that I
Yes,
have to
yes.
usually put it off.
Yeah.
The AI part of my or the bipolars, because telling me that now you stop coagulating sometimes becomes a little. So, Kumar, what about you? What you showed your hysterectomies, what are you more comfortable with?
Actually, if the surrounding tissues are not something bowel or something not close by, so I use advanced bipolar because the flaps are very large and I can shoot like with a shotgun, so with many pellets, so it's covering large area and so it's giving a good. I mean, I'm confident in advanced bipolar because most of the time I don't have the other energy devices with me regularly, but time to time available. But nowadays, actually, in my hysterectomies, if the bleeder is not controlling easily, I use advanced bipolar.
I used to use almost some 12 to 15 years for my hysterectomies. So the care hysterectomy itself has on a simple bipolar and scissor. But for the last years, as I mentioned, I have underbeat or an ultrasonic energy, mainly because lesser tissue trauma that it creates, it goes a little fast, bipolar and the scissors. Dr. Robotic, you do a lot of hysterectomy. What resource is usually available for the robotic at your end?
As you mentioned, I use bipolar and also scissor in the beginning of my experience. I used that for 5-10 years. And the same energy modality is used in robotic surgery. So in robotic surgery, we use bipolar energy and also the scissors. So it's very useful. So when you compare the laparoscopic surgery, so we don't need to use expensive energy modalities. Actually, you can do the surgery with only bipolar and the scissor. But if you have, it can make it easier for you to use this kind of energy modalities. So it's more faster and also it can decrease the complications during the surgery.
So when I was doing my post-graduation, that time it was not about laparoscopy, but I had one of my teachers who was very confident with his surgery, and what he used to teach me is don't worry about bleeding at any step of surgery. If it is a small bleeder, you catch with a small artery and ligate it. If it is a bigger bleeder, you take a bigger artery and ligate it, and that is the end of the problem as far as bleeding is concerned. Laparoscopy, definitely we are worried not only about the blood loss, but about the ischemic injuries which happens because of the lateral spread of the energy. So that is the main reason why we want to have a more careful approach about whether we are using bipolar or ultrasonic. Another aspect I wanted to ask Dr. Rasika, what is the lowest hemoglobin level that you accept for a hysterectomy patient or to be taken on table?
Okay, that's a good
You'll have to put yourself, unmute yourself, please. Unmute yourself. Dr. Rasika, you are not audible.
Hemoglobin of 8.5. So we are comfortable with hemoglobin of 8.5 before operation. If it's a simple, straightforward hysterectomy. 9, yeah, depends on the anesthetist confidence also. Definitely 9, we wouldn't give anything more than blood.
That's basically how much is the anesthetist confident in your surgery.
Yeah, yeah.
Dr.
So we've
Nishen,
been working together with my anesthetic team for a long time. So we are very confident to operate around 9. Yeah.
Dr. Nishendra, what about you? What is the cutoff of hemoglobin that you are comfortable with?
Yeah, I think I also have a very good anesthetic team, senior guy, and he's been. It's dependent on the patient. If it's a bit of a difficult hysterectomy, we're expecting bleeding, like had a previous endometriosis and adhesions and all. The 8 would be the minimum. Then Oh yeah, so 8 would be, I think, would be probably the safe limit. And sometimes the patient is, like it's a very simple hysterectomy, they're still having bleeding and in acute conditions where you need to do the hysterectomy. The patient is otherwise okay. Even between 7-8 is also okay, provided that blood is ready. And then if there's any unexpected bleeding, we do transfusion during the surgery, or after that, looking at the hemoglobin level and the clinical picture. The other thing,
What is
yeah,
your belief regarding the use of injectable iron for building up the hemoglobin?
of course, I don't think we don't have to wait till injectable iron to give and then wait till the HB to come up, because in that case, giving oral iron and then control the bleeding with other measures like progesterone or maybe some continuous hormonal treatment will help them to increase the hemoglobin level before the surgery. I have seen many patients when you stop the bleeding with some progesterone long-term therapy and giving iron tablets for maybe 4 weeks, 6 weeks, then the hemoglobin will come up to the levels 8 or 7 or more than that, make the patient suitable for the surgery.
And what about post-operative? Suppose you have operated on a patient with hysterectomy 8 or 8.5. Post-operative, what do you recommend for the build-up?
If it's a simple, straightforward one, is not bleed a lot. So then, of course, we are starting the iron therapy, the tablet forms. And then, of course, when we see that we are clinically okay, not having the features of severe anemia and not dizzy and could cope up with their day-to-day work, we let them go home. And then probably we check them in a week's time, only if they're complaining symptoms of anemia. Otherwise, oral iron is alone is enough.
Dr. Mehte, what is the cutoff of hemoglobin in your OT?
Before the surgery, we would like to have at least 9 grams of hemoglobin. After the surgery, if the hemoglobin drops to 8 grams or less than 8 grams, generally we replace with blood transfusion. And upper than the 8 grams, we generally replace with the iron tablets, and send it to home.
Yes, even at my place, I have a cutoff of 8 as hemoglobin. And if there has been any bleeding during the surgery, then we give injectable iron post-operative on the day of surgery. Otherwise, we recommend patients to take it at home as tablets or syrup. And that usually suffices. Sometimes the problem which I have seen is if the hemoglobin has been low, like 8 or 8.5 or 9, and if the raw area that I leave inside is significant, like for example, it's been endometriosis case and there is a lot of raw area or charred area, those patients definitely tend to come back in the 3rd week with bleeding or significant hemorrhage happening per vaginum. So from that purpose, now recently I have been a little bit particular that if the hemoglobin has been low, we specifically advise them to either change the diet or to strictly adhere to the tablets. Otherwise, give injectable iron once a week for 4 weeks. And Dr. Kumar, what has been your experience with encountering any bleeding requiring a laparotomy on table at your place? Have you ever had to convert a patient into laparotomy?
Actually, I don't have my all the laparoscopies for last I think 8-9 years. I did open a single one, so
good. That's nice.
Everything fine. And so I usually keep to be safe side. I usually keep the hemoglobin around 9. The reason is when the uterus is bigger, with the uterus, certain amount of blood is going to lose. So in that case, we are keeping around 9. And so if patient is asymptomatic post-op, so we can discharge the patient with hematinics, and we are reviewing probably maybe 6 weeks time.
Open question to all the panelists. Have any of you encountered post-hysterectomy bleeding in 2nd week or 3rd week of surgery?
Yes. Can I answer that question? Yeah.
Yes, please. Yes, please.
Yes. I have a couple of patients who had bled, not significantly, but they were complaining continuous bleeding. And I had a look, and then I saw that vault was bleeding. I probably think it was an infection. I treated with antibiotics a couple of times, but still it was continuing for 1 week. And then I put some yeah, initially I was trying to find any granuloma tissue or any bleeding point in the wall, but still I couldn't in those two different cases. But they bleeds and stops and comes back again and bleeds, but patient was not happy. But with tranexamic acid and the antibiotics, and also I put some clindamycin vaginal the gel, and in about 4 or 5 days they got settled. But all 5 days it was a kind of I had to answer all their questions and like to reassure them. And I had about 2 cases. Yeah.
I had the same
Uh,
experience. Yes, please, Dr. Mehta, kindly.
Yeah. Yes, of course. Yes.
Yeah,
Dr. Mehta.
I'm sorry. Actually, I have to answer why we are bleeding after 3 weeks or 4 weeks after a laparoscopic surgery or hysterectomy. So in these cases, probably we need a surgical correction maybe for the bleeding. We have to find out the bleeding point, and maybe we have to do some procedure to stop the bleeding. So firstly, we have to find out the reason of the bleeding after 4 or 3 weeks, after a simple hysterectomy.
Dr. Sampath, what was your suggestion? What was your
Yes,
mention?
I also had the same experience. For publication, I have collected some data regarding this particular aspect. I have done 110 TLHs with barb sutures, and in that sets of procedure, I used to lock the vault at the end, the one end. In that sets of patient, I got 3 secondary suturing after 2 weeks. Then it was a kind of significant bleeding, and then I shifted from barb sutures to the Vicryl because of financial reason of the country. The people cannot afford barb. Is expensive in Sri Lanka. With that, at the same time, I use Vicryl number 1, and but I didn't lock it in at the end. But I got only 1 bleeding after 2 weeks, and I did some kind of literature survey regarding this matter. It says there's a rupture of descending vaginal branch of the uterine artery or something like that. And there are some occasions they got the patient to the theater and ligated it. But in my case, there are 4 patients. I didn't want to do any significant intervention, as Dr. Professor Nishendra said, tranexamic acid, antibiotic, and sometimes 1 patient I packed and it got settled. But I don't know whether there's a correlation with barb sutures and looking it at the one of the end, which enhance the kind of rupture or kind of carving into the...
Yeah, so what I have experienced is in the beginning when I had started operating, I have also encountered maybe total of 7, 8 such cases in my experience. So wherever the ischemia is more at the vaginal cuff, so if you have used too much of bipolar when you are opening the vault, if the ischemia is significant, then in the 2nd week, that dead tissue is likely to slough out. And then in that situation, when the tissue is getting sloughed out, if there is somehow some ascending infection which goes in, that might cause the lateral vaginal angles to open up, and then there is bleeding. So in none of my patients, we have had to do any surgical intervention. Though we admitted the patients for 3-4 days, gave them injectable antibiotics, and it settled with conservative management. And also, like I mentioned to you, that we also shifted from barb suture into 2-0 Vicryl interrupted sutures. And it has not happened in the last 5-7 years. But I think ischemia, even if you are tightening the vaginal vault very tightly, that suturing ischemia can also cause the same problem, I suppose. Dr. Rasika, you have any opinion?
Yes, actually, Actually, we used to close the vault with barb suture, and one problem I had, can you sorry, there's echoing here. Can you
Yeah,
open
yeah, you'll have to have only one device from the room.
Yeah.
Yes.
So we're just struggling on this.
No issues, no issues. We are waiting, no hurry. I mean, it's an informal thing, so no issues.
Okay, sorry about that.
Yeah.
So the problem we had was recurrent vault dehiscence.
Yes.
Initially, the patient went home and then she came back with the dehiscence of the vault, which we sutured actually vaginally under laparoscopic guidance. We had a look from top, examine the vault, and then sutured it vaginally. But then again, this patient came back with a recurrent dehiscence, which we had to support with a mesh and do a sacropexy with a mesh repair. And of course, we published this case in literature. If anybody is interested, you can search Rasika Herath recurrent dehiscence. It will come up in the net. So then we went through the literature. We thought that the incidence of vault dehiscence would be higher if we opened the vault with coagulation monopolar and then suture with barb. So we actually then changed our technique. We used to open the vault or to do the colpotomy with the cutting monopolar and then using absorbable non-barb material to close the vault to overcome this situation. So at the moment we also at the moment we use a normal Vicryl number 0 or 1 to close the vault.
Rajesh, can I talk
Yes,
about
please.
our
Yes,
experience? Actually, we are using VLAC suture for the last 10 years. We have some complications. One is bowel obstruction, because the small bowel go to the vaginal cuff and attach to the barb suture. And we have two evisceration. One is after 2 months, and the other one is after 6 months. And we repaired them. We generally close the vaginal cuff 2 layers, not so tightening, but we go to the left and come back to the right again, so 2 layers. So we didn't see any other serious problems because of the usage of this VLAC.
I think also probably the factor is how tightly I must have been closing it, because more than the concept of barb suture, I think the ischemia, which is more the causative factor. So moving on, we have one question from one of the attendees, Dr. Bhagya Jayashree. He's asked a question to the panel. What is your experience is using a monopolar hook for opening the vault? So any of you are using monopolar hook, and what has been your experience with it, please?
Can I come in? I think the evidence is that to use monopolar in a cutting mode causes the least necrosis of the tissues. So that probably gives the best healing opportunity to the vault. Yeah. So I think it's safer and best done in that, my experience.
Yes, Dr. Mehta, your opinion, please.
Yes, we are using monopolar while we are opening the vaginal cuff. We usually use the cut mode and not the coagulator mode. But we have to be careful, because it will be a little bit dangerous. Because if you push it hardly, you can damage to the closed bowel or the other important tissues. So you have to be careful while you are using this monopolar cautery.
Anyone else would like to comment on use of monopolar?
Yes, at the same time, I have been using monopolar for vault separation, and it's quite safe if you use it with well control. And I think it's better to use it with the vaginal cuff rather than using alone. At the same time, cutting mode is the best one, and it creates the minimum lateral thermal damage when it compared to the bipolar. I think it's quite safe.
Yes, I would also like to say that if you are using monopolar, you have to definitely use with a vaginal tube or a vaginal cuff, which is pushing the vault up from below. And compared to bipolar, the lateral spread of a pure cutting current of monopolar would be less. But I personally am more tuned with using the ultrasonic for the same purpose. So ultrasonic works equally well. And since I'm already using Thunderbeat for the hysterectomy, I'm comfortable opening just directly with the ultrasonic for the vaginal part. Kumar, have you used monopolar ever for the vault, or you're using only bipolar and scissors?
No, I use usually bipolar and scissors or other advanced energy source. But if no other instrument is working, I have used it once or twice. So it was actually not very, I mean, it was fine. And because I need to lift the uterus up with strong traction to keep the other structures away. And so can manage actually, no problem.
One more question for the
Rajesh?
panelist. Yes, yes, please. Yes, Dr. Mehta, please.
One more thing, we generally use uterine manipulator from the vaginal side. So
Yes,
we
so
use,
that is what the question was from one of the audience also. I wanted to discuss. What are you using as a person for hysterectomy? What are you using for manipulation of the uterus? Kindly elaborate on that.
we use, actually, your technique is a very nice technique. I have seen from you years ago. But we use generally Rumi or the other instruments from the vaginal side. So we use the monopolar cut mode. It's easy to cut the vaginal cuff. So we don't need to use a Thunderbeat or the harmonic to cut the vaginal wall, because it's difficult with the to cut it at the same time with using the vaginal manipulator.
Anybody else using a vaginal manipulator for the hysterectomy part?
Yeah, I think sorry, Nishant. So there are different types of manipulators available in the market, but the principle is that if you have a vaginal manipulator dilating the fornix and pushing the uterus up, the cadaveric studies, I think the studies coming from Germany, and they have shown that the distance between the ureter and the uterine arteries can be further extended by another 0.5 centimeter to 1 centimeter by using this technique. So I think it's safer to use a vaginal manipulator. The other advantage of having a vaginal manipulator is that it reduces the gas leak from the vagina. So that will help to maintain the pneumoperitoneum. So we use either the Donan's manipulator from Karl Stoss or Rumi, or we at the moment we use actually one Chinese which really doesn't have a name, but it serves the purpose. It helps us to antivert the uterus and then to get a good lining of the fornix, and it prevents gas leak. So I think it's very helpful.
Yes. So let's move on to the next part, which is the bladder dissection. So generally speaking, what we have a concept is, unless you have had a fistula, you have not done enough lap hysterectomies. So sometime or the other, when you're doing a lap hysterectomy, you are supposed to have either a vesicovaginal fistula or a ureterovaginal fistula. Till the time you have accumulated enough experience, you have to go through this also as a part of it. So may I ask the panelists, all 5 of you, to kindly let the audience know how many cases have you encountered in your own learning curve of fistula. Like, for example, I would start with myself. In the first year of my work, I ended up having 3 patients coming back to me with the vesicovaginal fistula. And I think that amount of fear which you get into your head because of the fistulas happening initially is something which you need to overcome. It's something which is going to happen with everybody, and unless you overcome that fear factor, it does not actually progress much. So let's start with Dr. Kumar. Have you encountered a fistula in any of your patients?
Yes, I think 2 ureteric injuries in hysterectomy and also one another ureteric injury in endometrioma removal surgery, cystectomy. One was complete thermal damage to the ureter, and the urine was leaking from the proximal end to the peritoneum, and it was corrected by the GU surgeon. Other one was a stricture. It was managed with the stent. The third one I had with the laparoscopic cystectomy for endometrioma. It was fresh injury and identified intraoperatively and sutured intraoperatively laparoscopically, and patient was fine.
Great. So, Dr. Mehte, what about you? It's been a long number of years of experience, but what fistulas have you encountered?
I have only one after a cervical cancer surgery, radical hysterectomy. That was because of the thermal injury, maybe, or the dissect so much dissection. So we devascularize the ureter, and we can see the ureteric fistula. So the main purpose is to prevent the complications. So we have to be aware of all these complications. We have to do the surgery according to avoid these ureteric or bladder injuries. So I have only one. I don't have any complication, this kind of complication in the last 15 years.
Nice. Dr. Sampath, what about you?
Yes, Dr. Modi. So far, I haven't had kind of fistula, but I had lots of, not lots, several bladder injuries. I had one, couple of months back even, that I just noticed the blood stained urine. Till then, I didn't notice that. And then I just inflated it with methylene blue and found that there's a kind of 2 centimeter like perforation there in the bladder. So far, I haven't got, but most probably I may not be that much of experienced person in this particular field. That's one reason. And
Yes.
it's a kind of, possible complication everyone of us can get, to be honest, I think.
Yes.
Can I come in?
We have also bladder complications. It's very it's very common, but you can detect during the surgery, and you can manage it easily. Actually, it's not a serious problem.
Dr. Rasika, please.
Yes, actually, I also had 1 or 2 injuries before and ended up in fistula. But I think at the moment what we are struggling is when we have senior registrars, we train them to do TLX and they end up at least 1 a year these days. But I think the important thing is that the commonest place where the ureter can get damage is at the close to uterine artery on the non-dominant, on the right side. If the operator is on the left side, I think it's important that the trainees, and when you're operating, when you're trying to get the uterine arteries, the best way to do it is probably to use a port on the right side of the patient to coagulate the uterine arteries. So if you try to coagulate the right uterine artery from a left port, there's a chance that you might cause more lateral damage and end up in a fistula.
That's quite true. Dr. Nishendra, your opinion, please.
Yes, there was during the hysterectomy, I had only one bladder injury, and that was a very simple hysterectomy because I felt very sure. And as you described in your lecture, I didn't go laterally. I lifted bladder from the top and then cut, and then I ended up in bladder. The other one was the ureteric injury. That was a difficult one, the initial part of my career. Now what I do is only place where I can see the ureter and the uterine artery could not be identified separately before the hysterectomy. I do the internal iliac ligation and also the ureterolysis, and going to the ureteric canal and try to identify the ureteric cause. And of course, even though I don't identify the uterine artery properly, and even if I cut it without ligating at the time that I wanted to ligate to separate the uterine artery, the bleeding will be very less. If the bleeding is is if I accidentally cut the uterine artery without separating the surrounding tissue, then I start, if anybody would start bipolar and energy, and that may cause thermal damage to the ureter if the ureter line very closely. So the precaution of uterine artery ligation and the ureterolysis, the dissection of the ureters, might reduce the ureteric and bladder damage.
Yes, that is true. We have a question from one of the audiences, Dr. Bela Kedia from Bombay. She's asking, what is your experience about disconnecting the uterosacral and resuturing them to the vault when you are doing vault closure? And what has been your experience with vault prolapse following the lap hysterectomy? So, Dr. Kumar, what has been your experience? Do you separate the uterosacral and reattach them back? And what about the vault prolapse?
Yes, I do. I do detach and reconnect. So I didn't have any wall collapse so far.
Dr. Mehta, what has been your experience with vault prolapse?
Actually, we don't, if it is possible, we don't separate the uterosacral ligament because generally we don't need to separate it. We use the vaginal uterine manipulator. So
Yes.
that's why we generally don't separate it. But if I separate it, I usually suture it to vaginal cuff. So there's a study, if you suture it to the vaginal cuff, you can prevent most of these possible prolapses after the surgery. One more comment, if it's possible, Rajesh.
Yes, please.
We generally recommend our colleagues in Turkey to see the ureter, to identify the place of the ureter just in the beginning of the surgery. Because if they have any bleeding during the uterine vessels coagulation, so you have to coagulate the uterine vessels. You have to stop the bleeding. So if you don't know the place of the ureter, so you can coagulate the ureter at the same time. So it would be difficult to find in a bleeding area to find the ureter. If you identify the place of the ureter in the beginning of the surgery, so it would be easier to find the ureter and avoid the complication.
Yes, yes. Dr. Nishendra, what is your experience regarding vault prolapse?
Not many, but I'm not quite sure whether they have gone into other hospitals because I'm totally working in the private hospital. The most of the hysterectomies which we did the patients in between 40s and 50s, and because they were the one who used to come with fibroids and heavy bleeding and all. There were few but I think it's not many.
Okay, moving on to the bladder injury, we suppose you have a fresh bladder injury on table which you have identified. How do you, what technique do you prefer to repair the bladder on table? So let's start with Dr. Sampath. I think you had mentioned about having opened the bladder. So how do you repair the bladder?
Yeah,
As in single layer, double layer, and what suture material?
actually, it says now single layer closure would be enough, but still I practice as a traditional way of I learned before. I use 30020 Vicryl with round body needle and mucosa to mucosa and the muscularis to the muscularis. That is the way of you repair the bladder. And end to end, the most important thing is not necessary to recheck the bladder with inflation of with methylene blue saline, and just to keep the catheter for at least 10 to 14 days, let it irrigate properly and it will heal by its own.
Anybody has any other opinion regarding the bladder repair?
Can I comment it?
Yes, please. Yes, please. Sure.
It depends on the defect on the bladder, of course, but if there's only 1 centimeter defect, sometimes you don't need to repair it. Just put the catheter and wait. If the defect is larger, we generally use again V-lock to repair the bladder, 2 layers.
What size V-lock? 4-0 or 3-0?
3-0 V-lock, 2 layers.
Yes, okay. I have had a few bladders which I have opened, and again the same thing. I also have started preferring the barb suture, 3-0 barb suture, a single layer closure. Important point here is not to strangulate the tissues, just approximate and leave it. If there is no bladder injury, I would like to ask the panelists, what is their opinion about post-operative catheterization? Do you catheterize the patient, and how long do you keep the catheter? We're not talking about injury, normal hysterectomy. So, Dr. Kumar, what about you?
So for TLH, I don't use a catheter.
Okay, and Dr. Mehte?
After a simple hysterectomy, we generally take it out in 4 hours after mobilization of the patient, because it's a kind of comfort for the patient in the first 4 or 6 hours, something like that. But after mobilization, we remove the catheter out.
Dr. Sampath, do you catheterize the patient?
Yes, I catheterize. Again, as Dr. Med said, I remove it after 4 to 6 hours. Especially, I keep the catheter for overnight observation sometimes, whether the patient get internal bleeding or and all those kind of things, where the patient produce adequate amount of urine. But in day surgeries, sometimes I do TLH in morning and send patient evening. In that case, I remove the catheter after a couple of hours.
Can I come in?
Yes, please. Yes, please.
Yeah, I also keep the catheter for about 2 hours just for comfort. Can I talk about a little bit of bladder injuries?
Yes,
Dr.
please.
Modi?
Sure. Yes, please.
Yeah, actually, I use more or less the same principles what you do. You use to prevent bladder injuries, but I go by 2 basic other principles. One is to let the pneumoperitoneum to do the dissection, and I follow the bubbles and white lines to dissect the bladder off. So I would get my assistant on the opposite side to hold the bladder up rather than the peritoneum. Hold the bladder, push the bladder up, and then use my left side ports to enter laterally into the space, the uterovesical space. So with the pneumoperitoneum doing the dissection, I'll follow the bubbles to push the bladder down. So that technique has helped me with the mobilizer in the phonics. That again helps to push the bladder down safely and to minimize bladder injuries.
That's quite comfortable. I mean, there are so many ways of doing a surgical step, and eventually every one of us ends up developing our own special technique of doing.
Own ways of doing it, yeah.
Yes, as long as things go comfortably, we are all good. Dr. Nishendra, what is your opinion regarding the catheter?
Yes, usually my theatre list is in the evening after 7. So we admit the patient during the daytime and do the surgery. And before the surgery, I put a Foley catheter, and that will help me, because if the surgery take a little longer, sometimes the pill in the bladder might give you difficulty in suturing the wall. So keep the same catheter till the next day morning, and then once the patient is mobilized, remove, and then let the patient go in the afternoon. And as Rasika said, my assistant is pulling the blood up. I asked my assistant to push the uterus up. So then I have control over the bladder with my left hand, and do the dissection of the right hand. So there I have more control and can go through the tissue planes much more easier.
Nice. Since we are about the bladder part, again, I want to extend it into one more part of bowel injuries. So I wanted to ask the panelists, what bowel preparation do you recommend to your patients for a hysterectomy? To give an example, like if I am doing a hysterectomy tomorrow, I allow the patients to have their meals in the morning, have some light snacks in the evening, and after 6 or 7 p.m. only liquid diet. And we give 2 tablets of Bisacodil, which is a laxative. in tablet form so that she's not constipated on the day of surgery. So this is simple bowel preparation that I prefer. I would like to ask each one of you, what is your standard bowel preparation method for the patient? We'll start with Dr. Mehte again.
Again, due to the surgery, for example, if it is a complicated surgery, we do the bowel preparation like the general surgeon's colon surgeries before they do the same thing before the colon surgeries. But if not a serious surgery, so we only give the patient bleed enema at night at 10 o'clock, something like that, around before sleeping, and she should be don't drink and eat anything after that time until the morning, until the operating time. But most of the surgeries we do not do any bowel preparations in most of the simple surgeries.
What about you, Dr. Kumar? What bowel preparation do you recommend to your patient?
Actually, initially, if I am expecting bowel adhesions like previous multiple surgeries and endometriosis, at the beginning, I mean, few years ago, I used to give liquid diet on the previous day, and also give a clean prep, and then keep the patient on liquid diet until the night, and then I operated. But after reading literature and all those things, it was said that this bowel cleaning is no scientific basis for the infection. So it depends on the surgeon who comes to repair the bowel damage or something. So it says there's no scientific basis for the prevent infections or minimize infections. So I actually stopped that practice. So at the moment, I'm also using 2 Dalcolax previous day night, and then operating the next day.
Dr. Nishendra, what about you?
There's no food restriction. So the patient comes with the breakfast and the lunch is also they're taking. So I give you a clean enema about 2 hours before the surgery. And but actually, in a patient who has a risk of having bowel involvement, and then I still use this clean prep or move cold low, something to clean the bowel, and giving them orally in the morning. So for 3 hours, and by 3:30, 4:30, they start opening the bowels, and I still practice that.
Dr. Rasika, any opinion regarding the bowel preparation?
Yes, unless we are expecting major bowel adhesions, we also don't do any bowel preparation. But as Dr. Nishendra said, I prefer to give a clean enema a few hours before the surgery to keep the rectum empty during the surgery. So, yeah.
So, Excelite or Pegleg, that was the colo preparatory liquids which are available in India. That is something which we definitely don't recommend because it sort of dehydrates the patient quite a lot. So, like Dr. Kumar said, that excessive emptying of the colon or the bowel probably does not really help if you are going to accidentally open up the bowel. If the suturing is good, there should not be any problem related to that part. So similarly for the bowel closure, any particular recommendations that you have regarding bowel suturing or bowel closure if it happens, specifically for small bowel as well as for the large bowel? Dr. Mehta, will again start with you.
Yeah, if you have a small bowel injury and if it is less than the 50% of the bowel, we repair it 2 layers with V-lock again, barb suture again, perpendicular to the direction of the bowel. And if the injury on the colon, so we generally get some help from the general surgeons, but if it is a small defect, so we again repair it with the barb suture 2 layers again.
Dr.
We
Sampath?
clean the bowel. We clean
yes.
the bowel in serious surgeries, not because of the. We want to see the clean in the injured area if we need to repair it.
Yes. Dr. Sampath, any opinion regarding bowel closure?
Yes, me too follow the same way. Most of the small bowel injury or laceration, I myself stitch it. But there's a colonic injury or something like that, we get the help of a colorectal surgeon. And most of the time they do the primary repair rather than going to a colostomy or anything else. If it's a kind of benign condition, it's not a malignancy or something like that. Can I ask a question
Yes,
from the
please,
panelists?
definitely.
Yes. Is there any particular advantage or reason that you use barb suture instead of conventional Vicryl for bowel and bladder suturing?
In my opinion, there is no, but technique is more easier to use these bowel sutures for the surgeon. So there is no difference. I think there is no difference between two types of sutures.
Yeah, even I have the same opinion that suturing becomes simpler and easier with barb sutures. So that is the main advantage of using barb sutures for bladder closure also. There is another question from the audience. What is the advantage or experience of using an infraumbilical 5 mm port in being able to reduce ureteric injury? Like Dr. Asika had mentioned specifically that if you are trying to cauterize the uterine on the right side with the port on the left. So I don't personally have a habit of using a midline port. I feel it becomes a little inconvenient for me to have a port in the middle. There are people who prefer one left port, one middle port, and one right port. I have a habit of putting two left ports and one right port. Anybody would like to give an opinion regarding putting a infraumbilical midline port or a suprapubic midline port?
Can I come in? Yeah.
Yes, please.
I think I also prefer to have two lateral ports on my side, which is ergonomically very helpful. And suturing the wall will be very easy on using two ports on my side on the left of the patient. But if I'm operating low deep on the pelvis, it will be very difficult for me to access the left lateral pelvic wall with these two ports. So in that case, having a port in the in the midline, closer to midline, will be very helpful. I think this question comes who have read about French and European teaching. You go to Strasbourg and people in Europe, they try to practice a midline port about 8 centimeters below the umbilical port or a supraumbilical port. So having that port gives more access to lateral pelvic walls. I think that's my personal opinion. So yeah.
Yes, can I speak?
Yes,
As
please.
Professor Rastika said, when we go through literature, Western kind of surgeons, they prefer more suprapubic ports. One port from their side, one port from the opposite side, and one suprapubic port. And when it comes to the Asians and kind of more Eastern kind of countries, I think as Dr. Moody said, it's a surgeon side 2 ports and opposite side 1 port rather than putting a midline port. One reason is the people in that country, maybe, I don't know, to be honest, that but the art of doing that. And maybe the body structure wise, they are bigger and they can approach, and ergonomically, they won't feel much difference between manipulating those two ports. I think that may be the one reason.
Can I comment?
Yes, please.
Dr. Modi? Actually, I am old-fashioned, so I use two trocars, both sides, and one suprapubic. In my opinion, it's not bad. I can work from both sides with the mirror image. I can work from the right side, and also the left side, and on the same position. And the other advantages of this technique is if you need to extend the incision, so you can extend the suprapubic incision to remove something outside. It's more cosmetic. And also one more advantage is you can use a 10 millimeter or a camera port from the suprapubic port, and you can work on the upper part of the abdomen in the same image. So I'm working in this technique for the last 25 years.
Good. That is an interesting take. I mean, the advantage of being able to work on right and left is definitely there. And any other opinion? So there is also
I
a
think
question. Yes, please.
one point. Yeah, I think if you are doing a TLH and if you have a suprapubic port, I think the operator should be able to suture with their left hand to close the vault. Imagine a right-handed person staying on the left side of the patient. If you have a suprapubic port, I think it will be very inconvenient unless you are comfortable in suturing with your left hand. That gives the access to suture the vault.
There is also another question from the audience, Dr. Bela from Bombay. If you encounter a dilated sigmoid colon on table, how do you tackle that situation? Sometimes you have the bowel which keeps on coming on your field of surgery again and again. So in that case, anything you would like to advise as a tip to be able to manage it? Any of you can take that question.
Can I comment?
Yes, please.
I strongly recommend to excise the physiological adhesion of the sigmoid colon to the left side of the abdomen. So if you do this, you can remove the bowel easily to the upside of the abdomen. And also the second advantages of this procedure is you can go to the left ovary and the left retroperitoneal area, and also for the lymphatic dissection, you can go into the left retroperitoneal area easily. If you have a bulky sigmoid on the way of the instrument of the left side, so you can damage the sigmoid colon easily, and you cannot reach the that area easily. So I strongly recommend this adhesion to dissect this adhesion in the beginning of the surgery.
Yes. I think we should be able to wind up the panel with one last point because it's close to the finishing time. Any particular comment or tip that the panelists would like to give as per their experience, that something which they do is something which they would feel would be the carry home message regarding preventing complications? Anything specific that you would like to recommend? Like from my perspective, I've already given a whole lecture for the posterior dissection of the bowel in a frozen pelvis. If you use vasopressin into the uterus, it reduces the blood flow and the dissection of the bowel goes much more smoothly. Your chances of damaging the bowel are significantly less. So I need you to come up with some advice, either related to preventing bleeding or preventing bladder injury or preventing bowel injury to the audience from your experience.
I can, small comment about it. And of course, sometimes you come across the complications in difficult hysterectomies where you can't identify the tissues correctly. Simple step I am following is, without knowing what was it, without confirming what was it, don't cut. And if you feel like something to be cut, you just, if you don't know really what it is, hang around, go to another place and then dissect it and come back there. And maybe you can ask your assistant, or maybe you can put it to another side. And then again, you can prevent cutting important structures which actually you don't want to cut. The other one, the other one I had done is, once I put my camera in the middle port, and then I thought it was easy to dissect by putting the camera in the lateral port. Then I realized that the picture was totally different. And this is not there's something that you touch and operate, is something you get from your eyes, and then you memorize in your, like, keep in your head. And so once you just change the ports. You put the camera into the lateral port, then must be very careful, if not the dimension that you had in your mind would be the same, would be the real when you're looking at the different port.
So no experimentation regarding that matter.
Can I give my
Yes.
last comment? Yeah, I think two things I need to highlight. One is as a laparoscopic surgeon, this is my principle is don't confront the pathology head on. If you have a big addition, don't go to the pathology straight away on to the pathology. Try to operate laterally, come from where you can see the planes, try to work on bubbles and white lines, where develop the spaces. There are pelvic spaces, and try to work on spaces and try to come around the pathology rather than heading on to the pathology straight away. That's number one message. Second message, I think there are a lot of juniors that are listening into this. I think people think getting experience in laparoscopy is simple and short. No, the learning curve is a little long, and there are no born talented laparoscopic surgeons. It's a patient game. You need to be patient, and you have to pass through this learning curve slowly, patiently. So nothing like patience doing laparoscopic surgery. I think you need to develop that patience when you're going to be a laparoscopic surgeon. Yeah.
Yes, that is very true. And there is a saying which goes along with it. It takes about 2 years to learn how to operate, and then it takes about 20 years to learn when not to operate.
Yeah. Exactly. So deciding not to do something is the most important.
Yes. Dr. Sampath, what is your
Yeah.
suggestion?
That's one thing, as Professor Rasika said. One thing, the people think the laparoscopy is doing hysterectomy, TLH, but it is not. It's a bigger area than that. Doing the engineering and the ergonomics is quite important. No, you need to study on that particular area and learn more and more how to operate things, what are the ergonomics, and do simple things first, and then move with your confidence. The one last thing for the juniors, for the beginners for TLH, I always advise my personal experience, always use vaginal manipulator or at least vaginal cuff for the dissection of the vault at the beginning. This is quite easier and important, and it saved you from bladder and ureteric injuries. At least for some kind of, PVC sets of pipes, you can use different sizes. Yep.
They're quite easily available here. Most of the hand instrument companies, they provide the PVC vaginal cuffs to be able to elevate and cut on that. So that's a very sensible suggestion. Dr. Kumar, what would you recommend?
I think two things I came to in my mind. One thing is laparoscopy is not, I mean, we have a lot of trainees in our country. So we are in our unit also, we have many trainees. The thing is, so trainees sometimes might think that's the hands-on always getting, and we have to give something to do and practice. So it's also true, but the thing is, you have to watch as much as possible the surgeries somebody is doing at least. So it's a complete type of copying the whose technique or the procedure. So once it is much familiar to the eyes, so it keep in the brain. So it is so by assisting from other side, your hand skills will improve with time. So then once your eyes are ready and brain is fixed with the procedure, so it's easy to go ahead. The second thing, against what Dr. Nishendra and Rasika said, they said both they are not cutting if the pathology is not identified something, but I do something different because sometimes person pelvis, so you cannot identify it, so everything gone. So in that case, what I do is I go laterally and identify the ureter and drop it and separately. I can see the ureter. So once I see the ureter and make sure that bowel is away, I cut the other things. So then, so it's the pathology because the tumor, whatever the fibrosis, the cyst, and the diseased ovary and everything. So if the vital structures are separated, then cut to the pathology. So it is also another technique I have practiced in person pelvis.
Good. That's really nice. So we will have the last opinion from Dr. Mehta, please.
Yes, thank you, Rajesh. I would like to remind everybody that the many complications, actually more than 50% of the complications happens during the first insertion of the trocar, the camera trocar. So we have to remember it always. So we generally use Veres cannula before the insertion of the trocar. So if you use Veres cannula and do insufflation before the insertion of the trocar, please do the pressure 20 before the insertion of the first trocar. So one of the advantages of the Veres cannula is when you have a problem, you can damage the bowel with the Veres cannula. But if you use the direct insertion, as the Kumara did it, you can go into directly to the bowel. So you don't have any chance for the second chance. So if you have any problem during the Veres cannula, you can change the position, you can change the point of the insertion place, or you can do then open surgery if any problem during the Veres insertion. So the other thing is for the avoiding for the bowel injury or to detect during the surgery, don't change the position before looking around with the camera. After checking the bowel is okay, and then change the position and make the patient Trendelenburg position. And I recommend everybody to use a manipulator, what kind of manipulator is that, but always use a manipulator during an hysterectomy.
Thank you. Thank you for the inputs. One last input is from one of the delegates attending from here, Dr. Hemant Kansal, who is suggesting as his point that ultrasonic energy is definitely better to prevent bladder and bowel injuries. To a certain extent, it is agreeable. I take the opportunity to thank the Sri Lankan College and Dr. Kumar for organizing this particular panel discussion and the whole event. Thank you very much from the bottom of my heart to the panelists for being with us and sparing your valuable inputs on this entire panel discussion. Thank you.
Same here, Dr. Modi and Mete, Dr. Prof. Mete, and now the panelists, our president and the academic chairman, everybody. As the subcommittee chairman, I would like to thank everybody for excellent event and went smoothly. Thank you.
Thank you.
Okay,
Thank you.
okay, I think it's time to wind up a very successful webinar. And I know there are a lot of questions on board yet to be answered. I know that there are some time limits. And I take this opportunity to thank especially Dr. Kumar, because he was very instrumental in organizing this. And the Dr. Modi, I know this with your expertise and the experience over decades. I think you share your experiences. I think this would have, definitely this would have been an eye-opener for the beginners. And then I know even the consultants, got this chance to refresh their knowledge. And I think in turn, this would be beneficial for the women in the country. And so all the panelists and Dr. Meet and Dr. Sampath, Dr. Professor Rasika and the Professor Nishendra. And again, thank you, a big thank to you all. Thank you very much.
Thank you. Thank you,
Thank
Dr.
you.
Mehta again.
And
Thank
again,
you.
I'm taking this chance to thank this Tidus Cadilla, and so because they are always the helping us for us to arrange all these webinars and all. And Shivani, thank you very much.
Thank you.
Thank you. Thank you for everybody. Thank you.
You all. Thank you for the invitation.
Thank you very much, everybody.